All right. Well, good afternoon, everyone.
Good afternoon.
My name is Eric Bridges, and I'm the president and CEO of the American Foundation for the Blind. And we are so happy to be here today to share the information that we've gathered with you all so that it can be shared further on into this great state of West Virginia. Want to thank Dr. Leslie Cottrell with the Center for Excellence in Disabilities and the West Virginia University School of Medicine, Charleston campus. Also want to acknowledge and thank Shelley Atkins with the James H. and Alice Tubert Charitable Trust. Thank you both for your continued support and collaboration with the American Foundation for the Blind today. AFB, who are we? The American Foundation for the Blind. We're a 105-year-old nonprofit organization that really exists to expand possibilities for people who are blind or have low vision. How do we do this? Well, a lot of the work that we do centers around public policy, advocacy, research, and strategic partnerships. And so one of the things that we're so proud of is that in part due to the Tubert Charitable Trust, as well as other charitable organizations in West Virginia, for nearly 3 decades, we've been partnering with organizations in the Mountain State to provide information regarding the things that are actually going on in the lives of blind and low vision individuals, and how to create greater levels of independence and security. This topic that we're going to talk about today, aging and vision loss, is one that is not unique, but West Virginia, being one of the older states in the country, is seeing, we're seeing things develop here. For example, about 4% of West Virginians claimed to have significant challenges in being able to see. It represents roughly 70,000 West Virginians. And of that 70,000, about 43,000 are individuals who are over the age of 55. So rather significant. Nationally, by the year 2050, the incidence in vision loss and blindness is expected to more than double. So this is not just going to be a West Virginia challenge. This is a national challenge. And this is no longer just a niche issue for folks in states to deal with. Folks, who are the folks? Well, they're the doctors, the nurses, the clinicians, and others who are dealing with patients of a certain age that are experiencing vision loss. So, what do we do about this? How do we begin to explore this and talk about it? Well, you're here today, so that's good. The information that we're here to share with you all today is really seeking to take the research and translate it into what we like to think is helpful information for you to share with your groups as you leave. We want our research to be utilized so that it can have the impact that we feel like it can have, and that you all can begin to see results from patients. And what do results look like? Well, I would say increased, good outcomes, greater level of independence of the individuals that you all see. And with that, why don't we go ahead and get things started here today. I'm really pleased to be able to introduce our researchers, the ones that are actually going to be speaking the actual stuff and sounding smart unlike me. So with us today is the Director of Research for the American Foundation for the Blind, Arielle Silverman, who's leading much of the work on this topic. Dr. Priscilla Rogers, who is a senior advisor and somebody who's one of the foremost, I would argue, expert in this area of aging and vision loss. And then our researcher, Angie, who's done research most recently into kind of the qualitative aspects of aging and vision loss. And so with that, I introduce Arielle, Chris, and Angie. Thank you.
Thank you. Hello, everybody. I'm wearing a red, white, and blue flag dress. You know why? Well, first of all, I had to do this for a parade, but that's another story. Last week, I had to do a presentation on the aging and vision loss revolution. How about that? So I thought, hey, what's better than a red, white, and blue flag dress? And I'm still up here talking about an aging vision loss revolution, right? What can we do about making a change in this whole field, just like Eric talked about? So hopefully I'll be able to change these slides. Let's see. Of course not. Big part. There. Oh. Sorry about that. It doesn't like me.
It might have gone into standby.
Oh, seems to be up. Oh, you got it. Yep. You say feel good. Now. I'm glad we have Angie here because she is the tech person. That's not her real title, but that's what we're calling her today. Thank goodness, because I would be dead in the water without her help. Okay, so our objectives today is we're going to be talking about common causes of age-related vision loss and their impact on daily living. Also describing assistive technologies and simple interventions for older people with vision loss, tips for interacting respectfully with someone with vision loss, some of the psychological and systemic barriers limiting engagement in vision rehab services for older adults, and identifying how to locate and utilize vision rehab services and other useful resources. And you'll find out through the research we've done just how important that last objective is. It really, really is. So that's why we need a revolution. So, Eric has already gone over some of this stuff. This is big data prevalence rates. We know that as of 2024, 3.1. We have a note in here that said it's very difficult to hear the speaker clearly on Zoom. Anybody have another idea on how to make that better? Back in action. The tech person is back in action. Give that a shot. All right, can you hear me better? All right. Yay, we got a yes. Yay. Okay.
Yeehaw.
So, in 2024, according to the American Community Survey, 3.1 million Americans aged 65 and older said they had serious difficulty seeing or blind. Now, there's several different surveys out there, and you get numbers different numbers depending on how you ask it, but that's from the American Community Survey. And by the way, Vision Serve Alliance, which AFB is a part of, is in the middle of recruiting states that would like to be involved in a study to be able to get more data on their own state. So, for example, here in West Virginia, if you were to be engaged in that study, you would be able to get data that includes county level data, which has really helped policy planning and all, just knowing where your numbers are. But you have to enroll by the end of this week to be able to participate in it, and of course it costs some money. So if anybody's interested in finding out more about that, just talk to me after the program and I'll be glad to tell you more about that. I got it for us in Tennessee the last time around, and it's been really, really helpful to us in doing planning. So as Eric said, we have these huge numbers between 2015 and 2050. The number of adults age 40 and older who are blind is expected to double. A lot of folks that we're looking at needing to provide services to. And a lot of that has to do with the aging of the population. So I have a map up here that's showing the current prevalence rate of visual impairment for people 65 plus. And the dark areas on the map, which of course includes West Virginia and a lot of the west a little bit, have really dark areas. So we have higher prevalence rates in those areas. So I also wanted to talk about some other data that has become available. The Marshall University Research Corporation did a needs assessment study in 2022 in Cabell and Wayne counties. They had 98 residents who, in those counties, who reported being legally blind or having low vision, and who agreed to participate. So only 12.2% of people in that study reported receiving information from medical staff in an accessible format, such as large print. Or probably just getting information, as we will see it in the study that we're going to talk about later. They also talked about some unmet needs in terms of transportation, financial assistance, services, options for training and orientation mobility, and other types of vision rehabilitation services. Also in West Virginia, the disability compendium shows that almost 20% of West Virginia residents have a disability in 2024. And according to the CDC, West Virginia also has the highest prevalence rate of visual acuity loss of any state in the country. More than 1 in 30 residents have a visual acuity loss, and 12.4% of residents 65 and older are blind or have difficulty seeing. So this university, West Virginia University, actually got a grant in 2024 to develop some innovative ways to prevent, treat, and slow the progression of vision problems. And I honestly don't know what the results of that research is, but we need to find out, because that's been a couple of years ago. So surely they have some information for us by now. So what are some of the contributing factors? The cost of eye care. Did you all know that Medicare does not pay for a dilated eye exam? Advantage plans will, some of them, but regular Medicare will not. So who do we have with the highest number of people with the highest number of eye problems? Does this make sense? No. See, revolution. What am I talking about? Transportation. In my part of the country, in Tennessee, we've done a study that shows that transportation has resulted in over 45% of the residents in my area not getting to a doctor to their eye doctor because they couldn't get the transportation. I am certain that you have a similar issue here in West Virginia. Rurality and lack of eye care providers. The diabetes levels. Here in West Virginia, we have very high rates of diabetes, high rates of smoking, and then, of course, a large number of residents who are 65 and older. We have 21% in the state. Other critical factors that we have found through the big data study is that educational levels are relatively low among older people who have vision problems. 28.7% have less than a high school degree. 10.6% have incomes of less than $10,000. 11.5% delay health care because of cost. 33% have some kind of hearing impairment. 27% have depression, and 51% report poor affairs. So we know we've got all these issues going on in the background, in addition to the visual impairments that we're talking about, which makes the necessity for service delivery that much more important. And then we come to falls. In the U.S., 46% of adults 65 and older had falls versus 27.7% of those without severe visual impairment. The overall fall rate in West Virginia is 33% for older people. 33%. A lot of people are in the falls. And what are the results of falls? We know that. We know we're talking about broken hips, going to nursing homes, a lot of medical care, and a lot of times death as a result of it. So this is a major issue that needs to be addressed and can be addressed through vision rehab services. The economic burden of vision loss, which has also been calculated through CDC, is nationally the cost is $16,838 per person. In West Virginia, for people 65 and older, it's over $18,000. And for, of course, people 65 of age and older incurred the highest medical and nursing home costs. And when they did this economic study, they looked at the percentage of people getting rehabilitation services and that sort of thing. 4%. 4%. A lot lower than these other numbers, right? So, and we also had some other studies that show that less than 5% of older people who have vision problems use vision rehab services. So all these statistics I'm throwing around, it just shows us we have a problem. Whether we're exact on the problem, we know we still have a problem on people getting to the services. I mean, why? We're going to be talking about a little bit about that in a few minutes. So for those of you who are not in the vision field, and over half the people in this room are, because I know a lot of you already, we were going to talk about the difference between legal blindness and low vision. Legal blindness is basically a legal term that's used to define, the government uses it to determine who gets services. For example, Social Security or other types of things. And a person who is legally blind either has a visual acuity of 2200. You can only see that top line on the vision chart, the Snellen chart. That means legal blindness, or have a tunnel vision, 20 degrees or less on better seeing eye. So this is the better seeing eye. So you can have either one, and if you it's only in one eye, you're not blind. Okay, so for people with low vision, that it varies. You don't have to be legally blind to have low vision, but low vision can cause a lot of different issues: contrast sensitivity, being able to accommodate to being able even to drive, all those kinds of things can come along with low vision. I'm going to talk a little bit more about that in a minute. So on the vision spectrum, we have normal vision at 20/20 going up to 20/70 for visually impaired, 2200 for legal blindness, and then on to no light perception. So that's the whole overall vision spectrum. Also in the vision spectrum, we have the different types of eye conditions that can cause certain issues. So for example, with diabetic retinopathy, you often have scattered scotomas or blind spots in the vision. With macular degeneration, most often happens in the central part of vision, so it affects reading. And then with glaucoma or retinitis pigmentosa, you're looking at peripheral vision loss. So you may have what's called tunnel vision. And of course, a person can have all of these. And I want to kind of give you an idea, because a lot of people don't really understand. If you say you're visually impaired, they don't know what that means. You know, what are you actually able to see or not able to see? And these are just overall, this isn't an exact science, but it just kind of gives you an idea of how different people can see with different conditions. So visual impairment factors include acuity. We just talked about being able to see the Snellen chart. Visual field, we talked about field losses. Contrast sensitivity helps you. That will help you pick out stuff in your vision. So if you're trying to read something, if you have bad contrast sensitivity, it's really difficult to read sometimes because you don't have the enough contrast to be able to see appropriately. Then glare, light and dark adaptation, of course, poor night vision, color vision and monocular vision, and then depth perception. These are all the problems that can come along with having a vision loss. And they vary depending on the type of vision problem the person has had or does have and the types of services they've got, and including low vision aids, for example. So here are some other conditions that affect vision. Did you all know that rheumatoid arthritis can cause eye inflammation, cause vision problems, including glaucoma? Of course, we know that strokes can cause problems with loss of half of the visual field and double vision, and of course, visual processing. Parkinson's can cause double or blurred vision and difficult with eye movements or dry eye, and dementia. And that can lead to visual perception issues or problems with depth perception, peripheral vision loss. A lot of people don't realize this about dementia, and sometimes the loss of vision or visual perception anyway is the first thing that happens with that type of condition. So it's really important if you're working with someone to understand that you might have somebody who has both conditions. I had a person who was at my B&B not long ago whose husband ended up and the woman was telling me he couldn't find his food. And I said, well, have you tried using contrast so that the person can see? She said, no, I have all white plates and white tablecloth. I said, well, when you get home, let's try something else. And she did, and she emailed me back and she said, you know what? He can see his food now. Yay. But, you know, people just aren't aware of that sort of thing. So what can help? Lighting, reduce glare, contrast, like I talked about, magnification, verbal descriptions, using large font, at least 18 point. And finally, referring to vision rehab services for skills training. And that is just so critical. I cannot emphasize that point enough. And that's really what we're all about here. So what are vision rehab services? We have a number of them in our audience today. Yay! The folks in the voices union, and you can talk to them afterwards, but I'll give you the quick and dirty overview. Vision rehab therapists are the teachers who go into people's homes and teach them skills about whether it be cooking, being able to manage their home, being able to set it up, manage the medications, you name it, just the things they need to know to be able to continue to live confidently and independently and safely. Orientation and mobility specialists teach orientation to the environment and cane skills. Low vision therapists work with people with their low vision needs, with magnification, lighting, all those kinds of things that people need to know. Assistive technology specialists, we don't have a whole lot of those, but we have a few who teach the assistive technology skills, which can include the use of a cell phone, iPhone, or other kinds of access technology like speech with computers and so forth. And then we have some OTs who have some specialized training for vision as well. So those types of people are the ones who are able to help. And some of the interventions include magnification, from using a handheld magnifier to, on the bottom left of the screen, we have a digital magnifier. It's called a Ruby, which is a little bit bigger, and it will also change contrast for people, which is really useful. And then a talking book machine, which is a free machine that's available through the library service for people who are blind and low vision, or also for people who cannot hold a book. So all that machine and all the books that come with it are available by making an application to the library. Some examples of good contrast, which are, I have a couple of pictures here of a bathroom with bath mats that are green and a bar that you hold on to when you're in the tub that's different color, so that people can see that, know where the bar is. The contrast really makes a difference from having a white on white bathroom. And then a kitchen, which we have different colored, like the microwave and the clock and so forth are all standing out because they have contrast and so forth. So all those kinds of things that are simple modifications to make in the kitchen can really make a difference in a person being able to continue to cook and so forth. Also, this is a larger picture of a video magnifier. A woman who's working here is doing her arts and crafts using her video magnifier. And in fact, I know this woman. She was a peer advisor for a program I have been involved in the past, and she got a special award as an artist through the American Greenhouse for the Blind that has a special program for that, for artist recognition. So, and she used her video magnifier to make that happen. She was able to put her crafts together and want the board. Yeah. So, and also writing aids for people who are having a problem writing a letter, being able to take notes, whatever. We have signature guides, we have check writing guides, we have letter writing guides, bow line pens, all kinds of stuff like that that can help people. And none of these things are expensive things to do to help people. They're very, low cost but are just so effective in helping people to continue to do the things they still want to do, which is what we're here about, isn't it? Isn't that what we're supposed to be doing? So, yeah, I see people nodding. Yay! Yes. Okay, that's the whole idea. Just all right, I am through with my part for now. Yay! I get to turn the program over to Arielle. She's going to talk about digital devices. I'm going to turn off this microphone. She is going to be the 18th person. Here. All right. So we have this whole team approach to everything.
Honey. I think I'm going to turn the mic down just a bit now that we're using a different one. But on Zoom, if anyone ever has any trouble hearing us, please let us know. And if you have any questions in the chat, also let us know, and we will answer those at the end.
Okay. So I'm going to talk about digital devices and do a little demonstration, and then I'm going to talk about courtesy and etiquette tips for interacting with somebody who is blind or has low vision, especially in a healthcare kind of setting. So a little bit about me. I am totally blind except for a little bit of light shadow, and I'm 41 years old, so I'm not an older adult yet, but I'm definitely not a young adult anymore. And although I don't really have the lived experience of being an older person losing vision, I can talk about effective and in many cases, low cost ways to access digital information. So all iOS devices, including Mac computers, iPhones, iPads, all the eyes basically, have built-in vision accessibility features, including Zoom, not to be confused with the Zoom video platform, but Zoom is a screen magnification option on iOS devices. We also have VoiceOver, which is what I'm going to demonstrate, and that is a text-to-speech option that converts the text on the screen into audible speech. Because about 3/4 of Americans over 65 have a smartphone, it makes sense that these individuals should be able to access information, including reading, sending text messages, emails, communications to their family and friends, and using apps that might also help with other disability needs as well. Third-party software is also available. So right now, while I present, I'm using an earbud to listen to what is on the screen. I'm using a program called JAWS that converts text to speech in the Windows environment. And although I had to pay for that software, there's also a free application that does much of the same thing. So there are lots of free or low-cost tech options for older people who are experiencing vision loss. Now I'm going to do a demonstration using my iPhone. And I turned the speed of the speech down pretty slow, so hopefully it's comprehensible. So I'm first unlocking my iPhone.
2:40 p.m.
It's 2:40 p.m. I have a notification. I don't care what it's about.
Responding presentation 81,026. 1. PPTX. Actions menu.
That it's pointing to West VA 81026 presentation in my email. If I want to see what's in that presentation, I do what's called a double tap. So I tap it twice with one finger.
Image responding presentation share. Office print save to share print. Dismiss print. Office print share. Respond image.
But if I waited a little bit,
swipe up or down to select the custom action. Then double tap.
It will read me one slide at a time what is on this presentation. So I use my iPhone for pretty much most of the same things that other millennials use their iPhones for: texting and different kinds of apps. I use Uber and Lyft. I use GPS. I use all kinds of games, all the same kinds of apps that other people use, using this free built-in VoiceOver screen reader. So go to the next slide. And now I'm going to talk briefly about medication management, because that's also important for older people to find accessible ways to do. So I recently started using a service called Accessible Pharmacy, and we have the website for accessiblepharmacy.com. And so they provide mail order prescriptions, which is really helpful if you don't drive. And you can request your prescription in Braille or large print containers so that you can read the labels. You can also request accessible pill organizers, and you can use a system called Script Talk, which is kind of like a barcode that they put, but it's on the bottom of the medication bottle. And when you put the bottle into a Script Talk reader, or you use an app on your iPhone called Script Talk, it will verbally read you the information on the medication bottle. So those are all good systems for people with vision loss to use to independently keep track of their medications. There's also other ways that people can rig up their own large print or braille labels. Accessible Pharmacy also offers different kinds of bottle caps. So someone who has limited hand dexterity, for example, can use a screw-on cap instead of the childproof cap. So those are all useful resources as well. Now we'll talk about mobility. So I have a white cane that is folded up under my chair, and that is the primary tool that I use to get around, and simply tells me what's in front of me, tells me if there's a step in front of me, if there's an obstacle in front of me, what kind of flooring I'm walking on, and if I'm about to come up to a change in the flooring. So at the very basic level, a white cane keeps me safe, so I can walk around all the same kinds of places that fully sighted people can walk around, and I'm not at risk of falling or tripping, or unless I'm not paying attention, which happens sometimes, like does to everybody. The cane keeps me safe, but it also gives me a lot of really important information that I can use to learn the layout of a place, to be able to memorize and understand how to get from one area to another within, say, an indoor building or outside on the street. A minority of blind and low vision people, including some older adults, use guide dogs, which you've probably seen out and about, or maybe in the media. Guide dogs like Labradors, even some poodles and German shepherds and golden retrievers. And so they provide mobility assistance by guiding the user around obstacles, and sometimes also helping with finding landmarks and navigating through crowds. And then there's also technologies like Ira, which is a service where you can call and basically have a video call with somebody, and they can tell you how to get from one place to another, or they can do other things like they can read labels to you or help you navigate a website that doesn't work well with assistive technology. Some people also use a support cane along with a white cane if they have limited mobility. So going to the next slide. Let's talk for a moment about some stereotypes about people who are blind and have low vision. There's this idea that we live in darkness, and a lot of that is based on the idea that in order to be blind, you have to not be able to see anything. And as we talked about earlier, blindness and low vision and vision loss is a spectrum. And actually very few people are completely 100% totally blind. And even those of us who are totally blind don't necessarily experience darkness, either because we've never seen before, so that's all we know, or just depending on the nature of the blindness, it could be maybe you see all white, for example, instead of all black. So everybody's perception of blindness is different. Probably the most dangerous stereotype is some version of the idea that because somebody has limited vision, that they can't live independently, or that they can't even make their own decisions about what is safe and what is dangerous. A lot of times I'm in interactions where people ask me if I need help, and when I say no, they don't believe me. And so it's not just that they think I need help with something that's maybe very basic, but they don't trust my own judgment about whether or not I need help. And this is part of the stereotype that if somebody can't see, they also don't know what's around them. They're not knowledgeable, or they're not competent to make their own choices. And that, of course, is compounded for older people who are also stereotyped sometimes as not having, as having impaired cognition, for example. And then on the flip side of that, some people think that because we have limited vision, that we have extra powerful other senses. And the truth is that there's certain things that we might learn to do by hearing, smell, touch, or maybe even taste. But it doesn't mean that our acuity in that sense is better. It just means that we've practiced and learned to do a particular task in order to adapt to vision loss. So there are certain things that I can hear about traffic patterns because I've had to do that my whole life to be able to cross the street safely when I can't see a traffic signal. That does not mean that I can, I don't know, learn a whole piano concerto by ear. Like that's a whole different skill set. That's a whole different, and there's a whole different range of sensory abilities. There are some people who are blind who also have hearing loss. And so it's unfair to assume that everybody who's blind has amazing hearing because some of us have hearing loss. So we have the same continuum of our other senses that everybody else does. Some considerations in kind of an everyday interaction with a blind or low vision person, but especially in the healthcare setting. And AFB created a whole module that will show at the end called Best Practice Guide for Hospitals. So when you talk to a blind person or a low vision person, introduce yourself verbally, say your name. If you have a badge on for a profession or you work for an establishment, let them know that as well. So, you know, hi, my name is Mike. I work for the airport or I work for the hospital. If you're talking to a specific individual, address them by name so they know that you're talking to them. And please, please, please say something before you get up and leave, because we've all had the embarrassment of continuing to talk and then realizing that the person's walked away. Even my husband does that sometimes. It drives me nuts. It might be on purpose or not, who knows?
Just sounds like partners.
Yeah, exactly. Sometimes we might ask for guidance, and guidance can be different things. So sometimes if we ask for guidance to get somewhere, it could just be, can you tell me which direction to go to get to this place? Is it going to be on my left or my right side? Or if you're walking that direction, is it okay if I walk beside you? There are other times where somebody might wish to be guided by having the person who's guiding them walk ahead and allow them to hold on to their elbow. It's really important that if you're guiding, that you do not grab or hold on to the person who you are guiding. Instead, let the guidee take the lead and hold on to your elbow. There's a couple of reasons for that. If you're the one who's guiding, you're helping with the navigation. It's a lot easier to help with navigation if you're physically in front than if you're trying to steer somebody from behind or from the side. It's also a matter of preserving the other person's balance. So if you're grabbing somebody and turning one of their arms, pulling them by one of their arms, or pulling them by their back, it can interfere with their center of balance. And it's also just a matter of treating them in a dignified way and letting them have control, because ultimately they can't, if they're holding onto your elbow, they can decide to let go if they're not comfortable or they realize, hey, actually, I know where I'm going. So it's really important to ask the person if they need assistance, what kind of assistance, and not just, some people think it's either like no assistance at all or they want to be physically guided. Find out what kind of assistance they want or need, and then allow them to initiate by holding onto your elbow if that's the kind of assistance that they need at that moment. The same individual may need different kinds of assistance in different settings or even on different days, depending on, for instance, if they don't feel well, they might be more apt to accept the physical guidance rather than just walking beside you or getting directions. If it's in a place that's noisy, then the physical guidance can be easier, etc. This should be obvious, but it really is not. Unfortunately, speak directly to the person who is blind or has low vision, even if there's another person with them. That this happens a lot in healthcare settings. If someone who is blind or low vision happens to go to a doctor's appointment with a family member or a spouse, and the provider just speaks to the family member or the spouse, it's just insulting. Think about it. Would you want that to happen if you went somewhere with another person? Would you want to be spoken around? I don't think anybody would choose that. So please don't do that to others. Just speak to them directly. If they can't see your eye contact and they don't know you're speaking to them directly, you can use their name. You can maybe repeat your question a couple of times if you don't know their name. I don't really recommend like going up and tapping them on the shoulder unless that's the only way you can get their attention, or if you're in a more familiar relationship with them or they're okay with that. But please talk to the person, don't talk around them and say what does he want, what does she want? It's just very uncomfortable. Speak naturally. There's no need to raise your voice. There's no need to slow down your voice. There's no need to use pet names or talk to the person in a childish manner. Just speak to them normally. Go to the next slide. Guide dog etiquette. This is also should be self-explanatory, but this is often violated in real life. If somebody has a service dog, which may be a guide dog, but it could also be a different type of service dog. If they have a harness and they're in harness, pretend the dog is not there. Do not speak to the dog. Do not feed the dog. Do not pet the dog. Do not do anything at all with the dog, because the dog is working and the distraction can cause a lot of problems both for the handler and later on for the dog and their training. And service dogs are permitted to go any places where members of the general public are permitted to go. So for example, in healthcare setting, guide dogs can be in the waiting room with patients. They can be in exam rooms with patients. They can't be in the operating room with a patient. But in most places, they can and should be permitted to accompany the patient. Don't grab the person with a guide dog. If the person wants human guide, you can offer your elbow. But a lot of times, guide dogs are really good at just following. So if you're guiding someone with a guide dog, you can just walk in front and the guide dog will help them follow you. Other etiquette tips. Always explain and ask permission before you touch somebody. And I mean, honestly, this is anybody. This isn't just people who are blind or low vision. This should be everybody in the world who's not like your spouse or your child. Always ask permission before you touch them, before you move their belongings, especially mobility related equipment like a cane, a walker, or anything having to do with their service animal. If you need to move something, ask for permission and also explain where you're putting the item so that they can find it again. If they're inpatient in the hospital and you move their stuff and then you leave, they could be looking around for their bag or whatever it is for a long time, which is not fun when you're in the hospital, I'm guessing. So just please let people know if you're moving their belongings around. Offer to read printed forms, because we often don't have sighted people with us to help with printed forms when we go to healthcare appointments. So offer to read printed forms, help fill them out. If there's discharge instructions, read those out loud and ask them if they want it in an accessible format, like either recorded or in some kind of like email or text message. And blind and low vision people still sign things. So if you need a signature, offer to help us locate the signature line. Some people carry small pocket devices like signature guides that they use to center themselves on a signature line, but offer to assist with that, and it should be a fairly straightforward process from there. And now we're transitioning to Angie's portion. Howdy.
You see me in the background a little bit. I'm very excited to go home and be able to tell my parents that those years in tech theater have finally paid off. And so, but now we're going to get into some of the qualitative work that we have done over the past few months. So for those of you who are not researchers, qualitative work is the stories, the lives, and the actual real life experiences of people who are older adults new to vision loss. And that's why we wanted to hear firsthand, because all of these data points are people too. And so we wanted to make sure that we told and respected their story as best as possible and wanted to share it all with you. So To begin with, we looked at a few of the agencies who do service, including the wonderful folks here today and those of you online. And we wanted to see what the individuals were confused about. So to begin with, there was a lot of confusion regarding eligibility. Many participants noted that they didn't feel blind enough, that their vision wasn't enough to be able to actually receive services. And that translated into other feelings of loss, of disconnect between their blindness and low vision. They did not feel like they could use that label or identity, even though it did fit what they were experiencing. They didn't understand what the services were, whether that was the actual definition of the services, what the intended outcomes were, or if it could even help them. And as a result, they frequently foregoed services. They were also very reluctant to identify as disabled. This is a unique experience for older adults that I think is not often touched upon. It is a new experience, a new life, a new identity that they are often fucking to accept. They do not like changes. None of us like changes, I feel like. And especially when this change feels so encompassing, it's often hard to embrace it. They're also struggling with assistive technology. It's too hard, or it's easier to have someone else to do it. They fall back on routines and do not have the capability to adapt without assistance and proper vision rehabilitation services, because these devices can be very complicated. But one of the most predominant themes that we saw too was that they believed that their experience was unique, that there was no community, that they did not share this issue with anyone else, and as a result, they did not feel like someone could help them. And then as well, there is the social cost of disability. When people around you also don't understand what you are going through, you feel disconnected from your community. You begin to draw back, pull back. You don't ask for help. We're doing a little bit of a jump back and forth with these because our clicker decided not to work too. Throughout our focus groups, we talked to people both who were connected and were not connected with services. As Pris mentioned earlier in our presentation, only 4% of adults experiencing vision loss over the age of what we looked at, 55, go to vision rehabilitation services, despite this being an incredible opportunity to regain skills or relearn the same things that they used to know at a heightened level of independence. And so we talked to people across the entire country, across all different ranges of life and education level, and we found several universal themes. And I'm going to start with the biggest one that I think is especially applicable to this room and those of you who are on our wonderful Zoom. Doctor knowledge. Doctors did not know about the services, did not offer handouts, pamphlets, any kind of access bridge to vision rehabilitation services, and therefore they had no opportunity gateway to actually understand that there were other options aside from medical models. If the doctor didn't know, how could the person know? When you are getting this diagnosis, something new, don't you want to know everything you can about it and what you can do? And who do you turn to for that aside from your doctor? And so it makes the most sense to have the doctor act as this opportunity gateway. And every single participant, and I'm not exaggerating, I mean it when I say every single participant noted that this was a deep desire that they had, or if they did experience it, it's one of the few reasons they actually went to services. So for those of you in the healthcare field, please, if there's one thing you take away from today, it's this. There's also the fluidity of blindness definitions and understandings. I touched on it a bit in the last slide, but there's also this uniqueness to an actual service barrier. The definition that many services use for blindness and low vision in order to get services for people to be accepted into their services varies from state to state to such a degree that you may qualify in one state but not in the other. And so people are left at a loss that they actually truly count towards these service patients. Another theme that was seen in every single person was a fear of losing independence in their way of life. They were afraid that by experiencing this vision change for the first time, that they were going to lose everything they knew. those stereotypes that Arielle talked about of constantly needing help are so permeated throughout our society that it ends up getting absorbed by these individuals that they cannot dissuade for themselves. Vision Rehabilitation Services offers this opportunity in order for them to regain their independence and feel more confident, knowing that their way of life is not over, it's just going to look a little different. We also noted that every single participant, whether they had already had services or who had not had services, wanted them. And so it's not like they don't want this, which is a common thing that people are saying, is that they're too stubborn. They don't want help, when that is the opposite of the truth. They want it, and if it was there, they would take it. And then also the difficulty of adjusting and accepting these vision changes. Many people asked, how can I go back, rather than what can I do? Diving into some of the quotes and stories from these individuals, we saw a lot of duality and division. So what people often said is whenever they were within their community, they either didn't feel like they were sighted enough or blind enough. One person noted that they said, like, I'm glad I have the vision that I do, but I also live in two worlds. You live in a sighted world, then you live in a partially sighted world. They went on to go and tell us how, as a result, they were no longer accepted into their church, but the local group for blind and low vision individuals also didn't accept them because they didn't do activities for older adults and other impairments that they may face. There was a strong denial across both service-connected and not service-connected. One participant noted that I had trouble accepting it, and honestly, to this day, I still have trouble accepting it because if I go to the doctor, he asks, where's my pain? And I say, it's at home. Well, why isn't it with you? Because I'm not using that stupid thing. This participant was very adamant that it was not something that she wanted to accept because it meant accepting that her life was changed. And that was a resounding issue that many of our participants also noted. And then the definition, I've mentioned a few times, but it's also something to note that by having a universal definition for blind and low vision, it can empower individuals by knowing that this one person said that by accepting my blind and low vision identity, it empowered me because I got to define me. And I think that that is something that by a shared definition could be easier to have and adjust to. We also saw a strong loss of hobbies. Both Chris and Arielle shared different ways in different AT that help people maintain and use the same hobbies. But for many folks, because they were disconnected from services or disconnected from the proper services, they were unaware about it. And that created one of the biggest senses of loss amongst our participants. From cooking to sewing to reading, many of them felt that they could no longer do it even if they were in services because no one has told them. Someone said that I had always cooked a bit, but now I'm uneasy with the gas stove, so I don't cook nearly as much. I use more frozen food than I ever did before, especially for those who are facing economic hardship. This may be difficult to add on top of. Frozen food is more expensive. For sewing, someone was talking about this beautiful quilt that they were making and beautiful napkins and said that they were making for their daughter-in-law before the vision changes. And afterwards, she noted that I can't hem the towels or the placemats or anything that I'm doing. They're going to have to be fringed edges, which don't last as long or aren't as neat as hemmed edges. And she felt a sense of shame by not being able to produce the same quality of work she used to do before. And then reading. Reading was the biggest heartbreak for many of our participants because they didn't know about things like talking books or magnifiers even. They didn't know about audiobooks, and they felt that reading was lost. One of them even expressed a feeling and a sense of illiteracy because they can't, quote unquote, they can't read worth a crap. Our participants did not hold back, if you can tell. One of the things that we came into this study questioning was if the messaging was the issue. And so was it just that the services weren't reaching for the right outlets, they weren't contacting the right networks, things along those lines? And many participants stated that their knowledge of services only came from their own search and effort, rather than any kind of information or intervention from other providers. They didn't get information from state agencies or doctors' offices. And so the messaging methods was not actually a promising issue, but the location was. And so when the messaging was connected, whether it was emails, phones, whether it was direct like house visits, once they were connected, any means of messaging worked, but getting to the actual messaging was the issue. All participants, regardless of their service connectivity, expressed a strong desire to get service information from medical providers at the time of diagnosis, even in a follow-up visit. One of them said, further elaborated that it would have been, if this would have been the case, they would have either been connected to services much quicker and felt like it was them, that they belonged, or gone to services even sooner and felt that not only were they accepted from the get-go, but they wouldn't have had that sense of denial, loss of independence, and could see the future quicker. One of the other barriers that Pris touched on that our participants also noted was transportation. But specifically, it was this decreased sense of freedom of movement. And that was what led to the loss of independence in many of their eyes. There was a common moment for many of them. It was called handing in the keys. I heard this phrase come up 10, 12 times across our participants, that the moment they had to hand someone else their keys, it felt like they were trapped and isolated because they no longer had that freedom of movement, especially in rural communities like here in West Virginia or Texas, where I grew up. There is no public transportation that is accessible consistently, or paratransit systems often have large wait times. They have large pickup and drop off windows, or they only service within counties. So if your doctor's office is a county away, you're kind of out of luck. There was even when there were centralized public transportation systems, like in more urban communities in Chicago, Philadelphia, New York, or other locations, they still felt isolated because the transportation wasn't always accessible, or information regarding paratransit left participants feeling more confused or unsure if they even qualify. That was one of the biggest cited reasons for our disconnected participants to say why they hadn't gotten services. They couldn't even get there. Then there's technology. As I mentioned earlier, assistive technology felt like a high barrier of entry for many of our participants because they felt that it was either unattainable for costs or learning barriers, that it was too difficult to learn, or that they didn't know if it would fit. Many of them wanted to try it out first to see if it worked, and that was not an option through either the doctor's office, the optometrist, ophthalmologist, or even from the company themselves. And if several participants expressed that if they had gotten a chance to try it out, those were service-connected and non-service-connected participants, and it fit, they were willing to forgo whatever cost it was to get it. But without that trial run, it was hard for them to accept the high cost. As one participant noted, I feel like it's such a simple thing. I got to be out there, but I've not been able to locate anything like this assistive technology. And this person specifically was talking about the video magnifier that Chris mentioned earlier. I just want to comfortably just sit and read something, but using my phone, I feel like I'm going back and forth, and it's not as enjoyable of an experience as it used to be for me to actually enjoy my hobbies. And I do want to say for those of you who are wondering, all of our participants who we did end up talking to, we did share resources with them, whether they were connected or not connected, such as like Hadley with their talking books and many of their learning series. And so while they were not connected to begin with, or they were connected to a degree, we have connected them further. There was also a vocational trend that we were not expecting. A lot of participants express that there were vocational barriers throughout their services, whether that was that they required vocation in order to actually obtain services to learn assistive technology or receive O&M, or activities of daily living training provided by the state. And then others required them to retire. They were not allowed to have some kind of vocation in order to receive services because they were of retirement age. Others went on to say that when they did want to have vocation and they had employment placement, it didn't align with their age, their past vocational experience, their learning credentials, or anything along the lines. They just placed them wherever it fit, regardless of actually considering the individual who they were fitting the spot for. For instance, we had someone who had a law degree, who was then placed in a fast food establishment. And that is absolutely wonderful if that's what they wanted to do. But the fact of the matter is they wanted to continue in the legal profession and learn how to use screen readers. They wanted to learn about video magnification, those kinds of assistive technologies. And the service provider would not allow them to learn from them unless they accepted the placement that they were given. There's also an immense amount of confusion, especially among the service-connected participants. So non-service-connected participants were definitely confused as well, but service-connected participants were confused about the outcomes of what their intended service was from the get-go. They were not told, hey, here are the challenges that we are trying to address. Here is what we view as success. Here is what we view as you knowing these challenges, or not knowing these challenges, I apologize, knowing how to overcome these challenges that you are facing. This is what it's going to look like. There was no communication about what the individual wanted out of the services. They didn't know about additional services afterwards and felt that even though they were connected, there was still a level of disconnectivity that stopped them or prevented them from continuing on. They were also confused about what agency to contact for further services, or even initially, because there are so many different agencies, state, national, community, both public and private, they were confused about what was the best pathway for them to continue services, get new opportunities. Who do I go to, especially if my old service says that's all we can do for you? And also, they were also confused about the services in general, what were totally out there. Were there like O&M, was it just what they had experienced, or was there more options? For activities of daily living, was it just learning how to cook and navigate the home? Were there more opportunities for them? And now for our non-connected participants, which is the 96% of them out there, thanks to the stat that we learned from Pris. I'm sure that this does not come as a surprise, but the biggest barrier was a lack of information or misinformation. Patients and providers and participants, all three of them were unaware of the service's existence, let alone any kind of options that they had. Some of them, especially several of the focus groups that we did in rural communities, did not know what vision rehabilitation services even were before we came and had the focus group with them, and still left sadly confused about it because it was overwhelming. And so the information, even when it was given, was misinformed, and they were confused about whether they qualified, where to get it, what it meant, everything. So many acronyms were thrown at them, is what they were saying that they didn't know what O&M meant. They didn't know what ADL meant. They didn't know what a VRT was. And so a doctor or a state agency just throwing all of this information at them didn't help. And then they did not believe that they had any qualifications to go in there. Again, that feeling that they were not blind enough, that they were not old enough, that they were too old. All of these definitions, by not being clear, concise, and consistent across, left people disconnected. They were also unaware if there were services in their area. Many of the participants that we talked to were in rural or suburban areas and felt that these were very niche services only available in bigger places, when One participant who lived in Nebraska, there was a clinic half a mile. And so she just didn't know it was there this entire time. She'd been experiencing vision loss for 7 years. And it was right there around the corner. As I've mentioned a few times now, the variation of the definition of blind and low vision, especially when it comes to older adults, and the variance across states and agencies, even within the states, led to a high degree of exclusion because the standards differed. So maybe they qualified for O&M through the state agency, but when they went to go get assistive technology through their county, they no longer qualified. Also, there were language barriers. There were ambiguity about what it actually means, O&M, but also for those who maybe English was a second language, there were not as many options for them because there was no language translation services in smaller areas. And now I'm going to leave you with what I feel was our most important and powerful quote. I want to express before I read this, that this person was service connected. It took them 10 years to get service. This person was 92 years old. I felt like I was going around and around trying to get services to get help. I kept a book. It was bigger than a journal. It was listing all of the places that I'd gone to, who I interacted with, what happened, going round and around all the time with everything. And what it was is that there was no centralized place to get information about these services. And the thing is that these services are where people should be able to know, and it's just not there. And so basically, it felt like by luck that I ended up finding it, which is not how it should be. And I could not agree more. But now what do we do with all of this information? These real life experiences, these stories, these challenges, and these new opportunities for change are available, but how does that look? And so here are some engagement strategies that we have come up with that we believe could be helpful. Increasing medical community knowledge. Those of you who are in the medical community who are here today, we thank you profusely because you are the first step in what we think is going to be the most successful change. Whether that is through medical knowledge, or medical school curriculum, or even just a handout, one piece of information can transform an opportunity for these individuals. Formalizing referral processes for doctors. Imagine if there was a streamlined pipeline from doctor to vision rehabilitation services. I see several people in the audience put their hands to their chests in relief, and I cannot agree more. If there was an online or even paper referral service, imagine how many more people are connected. It wouldn't be that 4%. And then just increasing the awareness of these services. Again, so many people were just unaware if they qualified or anything like that. And so by increasing awareness in the public, talking about it, tell your Uber driver, tell everyone you know about vision rehabilitation services, we're going to get the word out. And now I'm going to pass it off to Pris again, who's going to share some resources, some other amazing opportunities, and then we're going to get into examples of how we can actually translate this change. This microphone's working a lot better, it seems like.
I know we had some questions that have come up in the chat. So at the end of this presentation, we had a couple of case studies. We think we're going to forego those so we can answer some of the questions about the chat and here in the room. So we have a number of resources, and I don't know that I need to go through all of them. We do have some information that we brought along with us. They're on the table over here. We have QR codes with the information. And for those of you online, we will send out the PowerPoint to people, and we can also send the QR codes to go along with the information that we have available here. But we also have some things online like free resources for healthcare, aging, and social work professionals that are available through the APH Connect Center. The best practices guide for hospitals on interacting with people who are blind and visually impaired. Arielle talked about that a few minutes ago when she was doing her presentation. There's a vision health course at the Tennessee Public Health Training Center. Then the Mississippi State for OIB TAC, which is the only one. Technical assistance program has tips for helping people with vision problems. And then there's also a video on human guide text, Helen Keller's, that we listed on our resources. Other resources have division resources. NLS that I talked about earlier, the National Library Service. The Next Center has a lot of information on living with vision loss. And we also have some getting started guides through that have a lot of information for both family members and the person who's having vision problems. And they're in large print, and also soon will be audio format as well. And here in West Virginia, we have our West Virginia Department of Rehab Services, and we have representatives here today. They include individuals who provide employment types of services, as well as a visions program, which is visually impaired seniors and home outreach and networking services program, which is for people 55 and older who are not employed and have vision loss. So we've got an 800 number on here, 800-642-3021, but they're here in the audience, so take advantage of that. I'm so glad you all came today. Thank you for participating. So we wanted to have a little brainstorm. So what is your take on the psychological and systemic barriers to engagement in vision rehab by older adults that we've discussed here today? What do you all think? So say you guys, where am I? South. Do you have any ideas for remedies? What can we do besides what we already brought up, what Angie talked about a few minutes ago?
Used to be a teacher, so I'm not afraid of cold calling.
Yeah.
There's a psychological barrier that a lot of them have to get over themselves before they will even allow themselves to be in a place where they can accept any type of assistance at all. And when the lady says she didn't want assistance, it's not that she didn't want assistance, she didn't want to have to need it. There's a difference. So I think that addressing the psychological condition of vision loss and what all that change entails is really important.
One in the audience just mentioned that the psychological issues are really a major issue, and dealing with those is really important. Any other comments?
And raise your hand. I'll give the mic to you.
That'd be better so people on Zoom hear.
Right, test. Don't hear.
Do I need to turn this off?
Okay, I think I'm just gonna switch off with you. Virgo. All right, perfect. And so for those of you who, now this is not.
It's just you and me.
I know, right? It is just, it's me. I'm sorry. Here, I'm putting the microphone right in front of your face, sir.
So yeah, it's just a little guy.
Just a little mic. Hey, first of all, I wanted to mention earlier, I can't remember who's mentioned the prescriptions here in West Virginia. When you do that script talk, you need to find out if your pharmacy does that. You might have to shop around. And also CVS Pharmacy does spoken RX in West Virginia. Well, they do it nationwide. As far as what you was just talking about, I think the medical model, I don't know, I think that is a major problem. And I don't know what, I mean, you can give doctors brochures and give, I still think it's I was sitting in an examination room at my local ophthalmologist. I have RB. And the next examining room over was a guy who was just diagnosed with glaucoma. The doctor went in there and said, "You're going to go blind," and walked out. And he knew exactly where I work. I work for rehab. He could have said, "Hey, I know somebody that works for rehab. I could get in contact with him." He didn't even do it. So I think the medical model, there needs to be a lot of improvement. Maybe there needs to be a required course for all medical doctors, no matter what field they're going into, because it's a major problem. Knowing how to address and work with, whether it be blind, vision impaired, deaf, whatever it is. I think it needs to be done.
Gotcha. Yeah, absolutely. We also saw in the participants that several who had other disabilities also felt that it was too much. They didn't get service. And like you were saying, some doctors, you can lead a horse to water, but it doesn't mean they're going to drink.
So, just real quick, because I'm kind of wanted to build, like, I agree 100% with that. But kind of going off of what the gentleman had spoken of before, I was a caretaker a long time for my grandmother, and my grandmother and my grandfather. And whenever they started to need help, I think a big thing with them wasn't just so much that they didn't want to admit that they needed help, but they had a very different mindset being from rural West Virginia where you take care of your own. And they didn't want other people in the house, and they were very concerned about being a burden, even when it came to their own family helping out. And I think that that's very much a rural generational thing, but it's something that we have to start working people through a little bit more.
Absolutely. Yeah, that feeling of burdensome and even generational differences is absolutely something that we heard about. I think this microphone died, so I'm turning to my teacher voice. If you on Zoom cannot hear me, please let me know. But yeah, that feeling of I don't want to bother folks is a strong common theme. And I'll even share, because you mentioned your personal story. My own father falls into this criteria, right? It happened shortly after I joined AFB. And even then, he lives in rural Texas. It was hard for him to get services. And one of the reasons that he felt was because he didn't want to rely too much on folks, on his own family, because he was supposed to be the strong one, right? He is, oh, perfect. Marco. Okay. He was the provider in the family for a long time. He was, the strong, silent type. And now he needed help. And you're absolutely right. That is a generational thing, as well as just this feeling of I don't want things to change. Now on the screen, we have our little bit of information. So you can reach out to us if you have, we're going to get to some Q&A here in a second. But just for those of you who are looking at the PowerPoint, there's a screen with 3 of our names up, information about AFB, including how you can learn more about our research, because we have wonderful reports from the zone study coming out soon at www.afb.org/research, or you can reach out to us at research@afb.org. Now let's get to some questions.
Yes, Haley has a number of questions that have come up through the chat. The first question is, where should the guide dog be positioned during the exam or procedure? And should the provider ever ask that the dog be moved or separated from the patient? Here you go.
So I'm not the total expert on that. I believe the dog needs to be in the examination room with the patient, but Eric, do you want to answer?
Yeah, Eric, do you want to?
Cool, yeah.
Yeah, that's great.
Sure.
Surprise guest speaker, everyone.
Yeah. So my guide dog is now with me. He's getting ready to retire. But I've worked guide dogs for the better part of 25 years. So, and getting the pleasure of going to the doctor with your guide dog. The guide dog should be next to you, laying down next to you. And it is okay at times for the doctor or the nurse to ask you to please move the dog so that they can get access to one side of you or the other. Being unattached from your guide dog is probably not an advisable thing. Being able always to have the leash in your hand, even if you're on an exam table, is something that you can do. You can make a long leash and still maintain that, that coverage of having some level of access to your guide dog.
One more question.
I want to answer the second question here already, Eric, but there is a question, if the patient is sedated, anesthetized, admitted, or temporarily unable to manage their guide dog, whose responsibility is the guide dog, and what should the healthcare team do?
So in May, I had a colonoscopy, because I'm of a certain age now, so, but I left my guide dog at home because I knew that I was going to be incapacitated, right? So it's one thing to know that you will be incapacitated and to make arrangements to have your dog looked after while you are, hospitalized. It is another, I would say, to experience an emergency or what have you, and you're with your guide dog. That is something where I would think that the folks on hand could call your emergency contact to have that individual come and take care of your dog. In the meantime, I would imagine that the nurse or the nursing station would be a place for the dog to reside. Most of these dogs are extremely well behaved and adorable, and most people would want to be around them if you're incapacitated. But that's my opinion.
Another question here about the guide dog. What should I document in the medical record about a patient's use of a guide dog, if anything, so that future visits are accessible without unnecessarily labeling the patient or the animal? Right?
If anyone's online who knows the answer, please feel free as well. If no one knows, we will take a look and figure that out. Please shoot us an email and we can talk, figure something out with you. That way we can look into it and help you out.
Research at afb.org.
Yep.
Research at afb.org.
And Haley and Arielle, this is Leslie. I think these questions are great, and I appreciate you reviewing those. On the physician side or the provider side, many times they don't have a heads up that there's a service animal, that they're necessarily, it's not a given that what the individual's disability might be, what additional space might be needed in the room, so on and so forth. They go from one patient to the next, and that's unfortunate. So one of the systemic changes, this is these questions are kind of getting at that, but if somehow information can go in to the not the schedule, but so something that the provider sees, so that they can, if they need more than 15 minutes, they've got it. If they need a bigger room, they've got it. Some of those things lead to issues with interaction, not great quality of care. So thanks for talking about this.
No, thank you so much, Leslie. We really appreciate it. We want to give folks here in the live audience a second to ask any questions. We have a few more that we saw in chat, but we wanted to give y'all wonderful folks an opportunity to ask as well. So are there any questions, comments, concerns, decrees, declarations? Fantastic. Here we go. And then let me just, here is this. Please wait close to the mic and let me flip the camera around so you on Zoom can also watch the live Q&A.
Well, my question has to do with resources. You indicated that people can't find where the resources are, like the lady that lived half a mile away. So is there any place where there's an agency who is developing a specific list of resources by state or area, region, however you all break up AFB, if it's
Yeah, absolutely. That is a fantastic question. I see our Autumn pointing to someone back here. I will say I also know Hadley and the Braille Institute do some stuff, but let's talk to an expert here. Please introduce yourself.
Hello, everybody. My name is Chelsea Meadows. I'm from Aging Disability Resource Center. Sorry, I know there's people around. Hello, I'm Chelsea. So my director and I are here today, Brenda Landers, and we are from West Virginia Aging Disability Resource Center. So we serve around the state, but particularly just Region 2, which is 7 counties, 11, excuse me. And we are able to assist individuals with the waiver process. So if an individual would call us and they need individual help with transportation, I heard that a lot today. We can help try to find something in that rural area or just that county that they're in. If they need help with Medicaid, Medicare, we can screen them for that as well and also apply. And just as simple as if an individual needs help with an application. Application, especially for the aged population, is very intimidating. And just with my age, I'm 31, I'm still intimidated by filling out applications. So it's not just an age. We can help individuals that are 5 years old if that parent is just completely not knowing where to go. We have a hub with bridging resources, and they have a great website that's a plethora of just a wealth of knowledge. It's very overwhelming because there's not a manual to life and not knowing where to go, especially if you have grandparents. It's very overwhelming. So we can help. And to answer your question, you can give us a call. I did bring our information. You can either give us a call or you also can visit us at our Cross Lanes office or our website as well.
Could you share that number for us?
I never can remember that number. I'm going to let Miss Brenda give that number.
Yes. It's 866-981-2372. That's a toll-free number. We also have a direct number. It's 304-720-5861.
Thank you.
And we have a whole database of resources. We also have the we have an area agency for the Aging Disability Resource Center is a part of that.
Perfect. Thank you so much. We also I did check, Braille Institute has a hotline that you can call. I could not find the number, but we will share it out, as well as Hadley, Hadley has a hotline that you can also talk to that will get you connected and get you some resources. Here you go, sir, the microphones. It's a big one this time.
I have a big one this time. Also, I put together a resource guide several years ago. It might need to be updated a little bit, but it has national and state resources for the blind, ACB, AFB, NFB, of course, our agency, DRS, places you can purchase equipment, like Maxi Aids, independent living aids. It has a wide range of things in this resource guide. So if anybody would like that, see me. I'll get you my email is Kevin, KEVIN, _L, Manus, that's MAYNUS @wv.gov. Send me an email and I can send that out to you. Or I can give you my telephone number is 304-256-6900.
Thank you so much, Kevin. Thank you, Kevin. We appreciate it. Chris, do you have something else?
No, I think mostly it's the APH.
Oh, here, yes, please.
APH Connect Center has a webpage on blindness and low vision resources. They used to have a directory, they don't anymore, but that pulls all the stuff together we can talk about here as well, including the elder care locator, which is the national thing that you just talked about here in West Virginia.
Yes. And we're listed on that as well.
Awesome. And if they are a veteran, of course, you can talk to Veteran Affairs. They also have vision rehabilitation services. Any other questions from here in the live audience?
Yeah, I had a question.
Back to you.
Actually, I'm wanting your help.
Oh, okay.
There was a individual, I came for her, she's sitting down.
Arielle?
Yes, Arielle, I have a question for you. Sure. There was a navigation place that an individual could use. Did you say gyros? What did you say? I'm sorry.
IRA is a.
Let me bring the microphone back to you.
Yep.
Oh, I'm running. I'm getting my steps in today.
Happy you guys. I don't know what it stands for or if it's an acronym or not, but IRA is a visual interpretation service. And what that does is basically provides video calls with trained agents who can answer visual related questions. However, IRA is not free. They do have some free services, like you can do a 5-minute free call once every, I think if you're not a paid member, I think it's like every 48 hours. And most of the calls that I make to IRA are 5 minutes or less. It's just like, hey, can you help me find this thing that I dropped on the floor? Or what is this can of food labeled? Or, those kinds of questions. But they can also help with bigger things like navigating outdoors. They do not replace a cane or a guide dog. You need that physical mobility support. IRA does not replace that, but they do give you information through a phone call to be able to answer some of those questions. They are a paid service. There is a free alternative to IRA called Be My Eyes, and they are starting to actually both services are starting to phase in some AI, replacing some of the human visual interpretation, which we could have a whole other couple-hour conversation about that. But Be My Eyes and IRA do both provide human visual interpreters, and Be My Eyes is free, but the downside is that they are all volunteers, and so they're not necessarily trained in how to explain things, visual things through a video call.
And for those of you who are wondering, IRA is spelled A-I-R-A. As someone who just misspelled it, I wanted to clarify. Yeah, someone online has a question for us. For the individual who has 330 and ends in 596, please unmute.
Thank you. Can you hear me?
Yes, we can.
Okay, good. Just to let you know, the telephone number for Hadley is 800-323-4238. And you can also check out their website at hadleyhelps.org. That's HADLEY, the word helps, plural, .org. That's another free, like you had mentioned about Hadley, and I don't work for them or anything like that, but I do take part in different things that they do. Like they have several Braille workshops, and they also have like coping with vision loss, and there's all types of workshops that they offer, and also Bookshare. If you're a student with Hadley, you can get a free membership to Bookshare, which is another service for reading materials. If you're a student with Hadley, or if your Talking Book Library has some type of program that if you're with your National Library Service for your whatever state you're in, whatever, if that particular library can also help you with the Bookshare, that we have more access to books than just NLS. There's other places that you can access books. Over.
Excellent. Thank you so much for finding that for me and for all of us here. Also, for resources, your local library is a fantastic place for resources, whether it's talking books, assistive technology, or community events. Please support your local library. Yeah.
Oh, one more thing. If your state also has an independent living center, which serves people with multiple disabilities, not just blind people or whatever, check out your independent living centers. So, your state's Center for Independent Living, you could check those out. Over.
All right. Microphone. Does anybody have any further questions, either online or in the room? If not,
We thank you so much for coming today, and we will get this PowerPoint out and share it with anybody who wants it and the other resources that we talked about. We know how important it is to get that information. And please check out the resources as you leave, because we did bring some information along with us. We really appreciate you. Thank you so much for being here today.
Thank you all.
Thank you.